Welcome back, clients and guests, to my channel. My name is Jason Serro, and I'm a licensed professional counselor located in Connecticut. My videos are designed to educate and empower you to make informed decisions about your mental health. Please like the video, subscribe, and pass this along to friends and family if you think it will help them in some way. I am pleased to introduce you to Dr. Michael Blefeld. Dr. Blaifeld has been a pediatrician for over 35 years, specializing in the assessment and treatment of children and teens with Attention Deficit Hyperactivity Disorder, ADHD. He has been a trusted colleague of mine for several years, as we have provided coordinated care to numerous patients over the years. His expertise in ADHD has been invaluable to me in helping children and parents developing a comprehensive treatment plan. He has generously taken time out of his schedule to educate us on many of the essential components of ADHD criteria, its brain-based applications, meeting with the families, discussing medication options, and providing referrals to other professionals to assist with the treatment plan. I hope you learn as much as I did and use this information to make informed mental health decisions with your consulting pediatrician and therapist. Without further ado, Dr. Michael Blefeld.
I would be doing you an injustice if I didn't start with your fans. Did you know that you had fans?
Oh, no, go ahead.
Yeah. So,
Well, I've been around the block a little bit.
Yes, you have. I've got to read a couple of comments that patients have said about you. So, Dr. Blaifeld has seen my son since birth. He is now 15. My son loves him, and so do we. He is a very knowledgeable doctor and treats his patients with the highest respect. You can certainly tell he truly loves what he does, and we are very blessed we had the opportunity to have him as our physician. His care and medical knowledge goes above and beyond for his patients. He listens well and gives good advice and diagnosis. 20 years of the best care. So for the people that do not know you, can you introduce yourself and tell us who you are?
I am a 71-and-a-half-year-old pediatrician, and I began my medical training back in, first went to St. Lawrence University for my undergraduate work. And then I spent a year at Cincinnati Children's Hospital doing research, thinking I was going into a Ph.D. program. I actually worked in the lab where Sabin did the polio vaccine.
Wow.
And it was very, very cool. And the person who I was doing my research work with was actually a pediatrician. And he one day turned to me and he says, "This really isn't for you. You always want to be with the patients. You need an MD, not a PhD." Well, so I ended up going to Rush Medical College, which was actually the first medical college in the country, and it's in Chicago. And I did my training there, and then from there I went to Upstate Medical Center in Syracuse, New York, where my wife was from. And that was my promise to her, was that I have taken her all over the country, and now we get to choose. You can choose, you sit there and choose, well, where do you want to be? So the interesting thing is that there's something called the match program, and you put in where you want to go, and then the different hospitals put in who's their favorite people too. And anyway, I was very fortunate to match, and that was my first choice, and off to Syracuse we went. And during that time, I had my first child, was a 1-year-old. And then I started my internship there, and then residency, 2 more years of residency in pediatrics. I never, ever thought I was going to go into pediatrics. So I really didn't like kids because I didn't really know them. And back in my time at in Rush, they have you go around into the different areas, And I definitely wanted to be a surgeon. I wanted to do reconstructive plastic surgery on children with deformities. And I thought that was going to be my field. Well, I got into the OR and found out very quickly that my personality did not mesh very well
No,
in the OR.
didn't fit, huh?
No, not
Yeah.
at all. And so I scrapped that quickly, and then ended up in a psychiatry rotation. And the woman who was my mentor was a child psychiatrist, and she ended up opening up a whole world that I had never really understood of pediatrics. And the next rotation was general pediatrics, and that's where I said, this is it, done, over. And I knew that that was the right thing for me. So that's how I ended up in pediatrics, which I never in my life thought I would end up with. So that's how my progress went. And then I was in Upstate Medical Center, and that was a terrific training because it was a very prestigious hospital where people flew in from all over the areas, and for evaluations. And being one of the only hospitals in that region, when I was doing the neonatology part, we ended up taking helicopters and small planes and heading off to different areas to pick up newborns from little hospitals. And so that was really cool and a lot of fun. And then I decided that I wanted to do general pediatrics. Well, I finished there, and I ended up taking a job in Binghamton, New York for 1 year. And it was quite an interesting experience. I was overwhelmed with new patients very quickly, but realized that the area wasn't the greatest for us. And we always loved New England area. And everything in one weekend, everything kind of came together. I put some feelers out looking for other areas, and I heard from the chief of pediatrics at L&M, from a drug rep who did formula, told me about a practice in this area. And then another person told me about an opening in Mystic, Connecticut. And didn't really know much about Mystic, and we ended up coming down here, and the rest is history. And I joined Ben Kittredge, who had started a practice here many, many years ago. And we worked together for quite a few years.
Was
And
it just you two?
it was just the two of us. And we had an office in Sandy Hollow, and then Sandy Hollow Road in Mystic, and then we opened up a satellite office in Pawcatuck on Route 2. And that was going fine. And then Ben decided that he wanted to go off and on his own, and we dissolved the partnership. And I was living in Mystic, and he was living in Westerly, so he kept the office in Pawcatuck. I kept the office in Mystic, and then and I was renting at the time, and then the owners of the practice of the building wanted my space, and that forced me to change at that time. And so for my beginning years, and I was here, we came here 2 months before my third child was born. And I eventually became chief of peds at Westerly for a few years. And then when the split occurred, I had to make a choice of what I was doing. And that's when I ended up buying my condominium office in Groton. And because I didn't want to have to be moved out or anyone taking my space again. So, and then I switched at that point to Lawrence and Memorial. And so that occurred, and that was around 1990. and I've been there ever since.
So you wanted to plant some roots there at that time.
Absolutely. And the thing about practice was, and I always found that interesting, the word practice. Like, am I still practicing? When do I finally know what to do? You know?
Right.
And I've always found that to be an interesting word to use when you say my practice.
Yeah.
So, but I was, I came from a very high powered residency program where if you wanted to discuss, trauma care, you wanted to discuss oncology, unusual diseases. We had an unusual disease clinic where people couldn't figure things out. They would come in just for that. But in terms of community pediatrics or developmental pediatrics, I really knew very, very little. And so when I got here and started getting involved with patients locally and PPTs and IEPs and all these different things, I really didn't know very much. So I ended up doing a lot of training at Mass General Hospital. They had a great developmental pediatric program, and I used to take a lot of coursework there. And that's when I really began understanding this whole issue of ADHD. And it was at that same time that I remember listening to Michael Jelinek, who is chief of psychiatry at Mass General. And he at that time was talking about ADHD. And I was like, oh my God, they're talking about my son. And we had been getting those notes home from elementary school. Wonderful child, but he needs to stop talking and settle down and do his work. And so it was a very interesting, that's really how I began, because it was more on a personal level for my training in terms of developmental pediatrics. And really very, very few people in the area understood this whole area of ADHD, and I really didn't know where to turn. And during one of the conferences in Boston, I met a doctor named Russell Barkley, and he was up and new beginning, and he was in Worcester. Well, he was very, very kind and was willing to have me call him on Friday afternoons and discuss how do I treat my own child. And probably wasn't the wisest of my moves, but because you really shouldn't be doing that. But I didn't know who to turn to and what to do. So I ended up calling Russell Barkley at 2:00 on Fridays for a while. And he talked me through how to start medication. And eventually we did turn care over to a developmental pediatrician and take it off of me. But I remember very specifically starting on a Friday on a weekend, starting Ritalin, and on Monday morning we got a call from his teacher asking me to come in, and because I didn't say a word to him, and he called me in, and he said, "I need to talk with you. What's going on?" And he said, "I gave your son." He sat down. He did all the day's work. I put him into another room and had him sit down and do some more work. Well, he completed the week's work in the first few hours. What's going on? This has never happened. And then, so we had a long chat. And this is a teacher who was wonderful, who was Teacher of the Year at that point for the town of Groton. Anyway, or for the state, I guess they have the Teacher of the Year award. Anyway, that's really how my whole time began with all of this. So I don't know if that answered your question about, tell me about you.
Yeah, well, you definitely reached out to an expert. I mean, Russell Barkley
Yes.
does a lot of work in the executive functions, and I know that's provided a lot of my clients with some direction, especially in it's organizing themselves. So
Absolutely.
Yeah.
And lots of books, and also then I became very involved with CHADD, which is Children and Adults with ADHD, with ADD, CHADD. is the organization, and they actually have a magazine that they put out called Attention, and it's a wonderful organization, and one that I highly recommend people joining. So they have yearly conferences. It's always in the fall around November, and I started attending a lot of the ADHD conferences.
Excellent. You talked about ADHD, and I remember practicing several years ago, and I started my practice, and I started getting to know other professionals, and I started hearing more and more about this Blefeld guy. I'm like, who is this Blefeld that keeps coming up? Go to Blefeld, talk to Blefeld. ADHD, and he is the doctor to go to. And, I remember our first early conversations and really being in awe of your expertise in it. And then I started getting, all these questions from my clients about, first of all, really what ADHD really is, the confusion a little bit with the DSM-V, and, is it ADD? Is it ADHD? Is it still inattentive? Is it really inattentiveness? So, there's a whole lot. If you could speak a little bit to, what really ADHD really is.
Absolutely, because I struggled with it. So the DSM-V came out in October of 2013. And at that time, that was the DSM-4. So DSM is the Diagnostic and Statistics Manual that we have to use for diagnosing. And they give guidelines for it. And the difference between the DSM-4 to the DSM-5 for ADHD really didn't change all that much, except a couple of things that were really critical did change. And one of them was that you couldn't make the diagnosis of ADHD in someone who has another developmental disability like autism. So for the first time, you were able to say children with autism can have ADHD as well. And so that was a big change. And the other thing was that you needed, you have a criteria of nine diagnostic points for inattention. Oh, hold on. Here's the DSM-5. So for inattentive, you need 6 out of 9 positives, and the bottom is hyperactivity, impulsivity, and you need 6 out of the 9 for those to make the diagnosis. Come age 17 and above, you only need 5. Now, the bottom line to it is that I don't like the term ADHD at all. I don't think it's correct. And Russell Barkley in particular was one that pointed out a very big difference about what ADHD is all about, in the fact that it's more about motivation and not really about attention. So when we use the term ADHD, Attention Deficit Hyperactivity Disorder, that's my jumping off point right away for parents. I don't like the word disorder. Disorder means there's something wrong. And I absolutely do not think there's anything wrong with individuals with ADHD. As a matter of fact, it can be an advantage. So I try to demystify the term. And the other thing, it's not an attention deficit. So we say attention deficit. Well, if you have a true attention deficit, that should be seen in everything that you do. That is not the case in ADHD. If a child likes something, whatever they like, put them in front of a video game. Do they have a problem with attention? No, they can beat you easily because they're so focused in on that. But you give them math homework that's boring, and you're going to hear that term, this is boring. Everything is boring.
Yes.
And things that are boring, or the word for us is salience, things that don't have much meaning to them. That's the struggle with ADHD. And so they struggle with that tremendously. And that's one of the biggest problems. So it's really not attention. It's about how do you motivate that child to do the work that he doesn't want to do. Now, you and I, what's our motivator? A paycheck. We do things that we don't want to do, right?
Yeah.
So we all do that. So everyone has aspects of ADHD, but when it becomes daily and impacting their life, that's when we really look at it. And how do we motivate that child to do things that they really don't want to do, but they have to anyway? Because guess what? We all have to do that. But when it becomes an extreme difficulty, and to me, the whole issue here that I stress overwhelmingly to families is that I do not want kids to lose their potential in their lives. And if that's lost because they become demoralized, they get tired of it. After a while, they go in, they take tests, and no matter what they've done, they're still going to get that C, even though they know the work. That's when it becomes a critical time, because what are we really trying to preserve? We're trying to preserve their self-esteem. And if a child loses their self-esteem, that's pretty critical in development for that child.
What are some indicators of, when you meet with these children in your office and you start talking with them a little bit and you get the sense, yeah, this child has low self-esteem. What are some of those common elements?
They're looking at the ground. They won't look at me. They look other places. Now, I've always been trained not to make the diagnosis of ADHD in the office, meaning when you sit down one-on-one. And this is this is one of the things that separated me from other physicians in the area, in that I always have set aside at least an hour, if not an hour and a half, when I meet with a family.
Very thorough.
I don't do a quick visit, and it is by far my greatest privilege to sit with a family, which you get to do. But I don't get to do that in any other time of any other diagnosis in my office. Ear infections, 15 minutes. And now and insurance wants me producing. How many patients are you seeing in a day? Not what is the quality of the care that you're giving, how many you're doing. So our model of medicine goes counter to what I really want to do. So when I sit down and I spend time with families in a quiet setting, seeing that child shouldn't be the way that I'm making the diagnosis. A lot of people will see a child come in and it's a novel situation. They're a little more hyperactive. They get very anxious. Am I getting a shot? Do I need x-rays? What's going on? And they say, whoa, that's ADD. But you got to go slow. You got to really, really take the history. It's all history. There's no x-rays at this point. There's no blood work. And it's really historical. And you really have to spend the time with families, getting to know the family, because it has high heritability. 50% chance that your child's going to have ADD if a parent has ADD.
Oh, wow. It's that high.
It's that high. 30% if another sibling has it, but 50% if one parent.
Wow.
Yeah. And they're interesting because right now in 2020, we know there's 12 different genes associated with ADHD. Okay. Now, I can't tell from Zoom what your eye color is. There might be some. Okay, hazel. So you've got some blue in your family.
I do. Yes. My grandmother.
Blue. So take two genes, brown gene, blue gene. Okay, 2 genes. Blue is recessive. If everyone has brown, then you're not going to have blue eyes. But you have a blue gene in your family, your grandmother, you said, and that's how you ended up with hazel. Now, so that's dominant and recessive genes. But in ADHD, there's a minimum of 12 genes. None of them are dominant or recessive. There are no two individuals with ADHD alike. So we can't lump them into this grouping because they're all different. They all have what's affecting one may be affecting another one. And that's why when we use this DSM-5 and we try to slot everybody in and use the term ADHD and then think, is it inattentive type? Is it hyperactive, impulsive type? Or is it a combined type? It's very, very hard to make that. So I try to think of it more as a personality type. You're born with this. It didn't just all of a sudden, you didn't raise your hand in school and say, "Oh, give me a little ADD." You got it. And it's in the same gene area as other mental health issues like anxiety, depression, OCD, bipolar disorder, oppositional defiant disorder. These are all things that can run and can run in the same gene area. Doesn't mean if you get one, you get the whole whammy.
Right. Yeah, you don't get this onslaught of
but it opens up the discussion and allows people to be more open about family mental health sorts of inheritance. And so it's very, very important to look at it more as a personality type. So one of the things that I do right away, this is one of the first things, let me show you, because they all know this. So I hold a picture up here and I say, and I ask the kids, what movie was that from? Now it is dated, it is old movie, and it was from Hook. But Dustin Hoffman has been on Ritalin for over 34 years. And Robin Williams, unfortunately, has passed, but his hyperactivity was very well known in the movies. And then I also show, where is my other picture? Another picture I use is Thomas Alva Edison, greatest inventor of all time. But he was removed from school in the fourth grade and never allowed to return. And he has more because he was so hyperactive that they couldn't keep him in the classroom. So they removed him from the classroom and he never returned to school after fourth grade. He today still has more patents for inventions ever than anyone has ever had. So I try to, and then I hand out a sheet about famous people with ADHD, of course, lots of presidents and stuff, but these are highly successful people that think out of the box.
Yeah.
And I would much rather be in a room with individuals with ADHD than anyone else. Much more fun.
And much more creative.
Very creative. So you actually see in the arts highly creative people with ADHD, and inventions and CEOs. 50% of the CEOs in the country have ADHD.
You really come at this from a strength-based perspective. Instead of looking at flaws or defects or imperfections, you look at it from a really strength-based approach. This is what these are the things that you do well. And I think that really helps boost someone's self-confidence.
Absolutely. As a matter of fact, one of the things I try to encourage, find what your child does well and encourage it. Because in reality, that's going to give them a lot of self-confidence and it's going to give them an outlet as well. And it's really, really important. And we all have our variations in what we like to do. So, and I try to point out also that this is brain-based. This is not willful. This is not laziness. This is brain-based, and it goes back to 1990. This image is of a PET scan And it was done in 1990 at the National Institute of Mental Health. I happened to be there at this conference when Alan Zemetkin submitted this and showed for the very first time that ADHD is brain-based. This is not due to willful behavior or laziness. And it is in color versus black and white, which I love. Individuals with ADHD do far better with color. I know this for sure because I myself have ADHD. I wanted to orient you to the picture. On the left side is a normal brain, right side individual with ADHD. And you must know that it's not one is better than another, they're just different. And that's how ADHD is. On the left side, if you look at the very bottom, you'll see a whole bunch of white dots. This is the frontal area of the brain. This is where the eyes are. If you, in the back part of the scan, that's where the back of the head is. The brain has been sliced open by the scanner and you're looking down on the brain. Eyes at the bottom, back of the head in the back. Now, on the scan on the left, these two individuals were given something to do, and they were being scanned as they were processing information. The brain on the left, the normal individual, the white dots show enhanced activity, bing, bing, bing. They picked up, turned to white, which is the highest functioning, and showed that they initiated the task. On the right brain, there is only one dot, and you can see it towards the back part of the brain on the left side. There's a single white dot. But if you watched these two individuals, the brain on the right, that individual, after 8% lag in time, does catch up and eventually looks like the brain on the left. Here's a real quick aside, because I found this when I knew that we were going to be talking. I found this picture, and unfortunately, Calvin and Hobbes ended. Yes. But Calvin and Hobbes, deaf Calvin clearly had ADHD, and Bill Watterson actually came to one of the CHAD meetings, and was asked, does he have ADD? Because indeed, his understanding of the child in the classroom is classic. So I even framed this one because Calvin's teacher was Mrs. Wormwood, and he would go off onto these different journeys all the time, and down at the bottom, he's thinking of Spaceman Spiff, and he's off in space somewhere. And Mrs. Wormwood, his teacher, would say Calvin and calling him, and he invariably, though, got the answer. So, but unfortunately, that comic strip has ended. But it was very classic for a child with ADD that would go off in another world and miss half of what was happening.